Abdul Qahir Jawad, Coordinator Nursing Education Service, FMIC.
And I am Dr. Mariam Rahimi, Second Year Resident Radiology Department, FMIC. We will be your host for today's prestigious academic event. Distinguished guests, participants, and colleagues, it's an honor to welcome you all to the 10th FMIC Annual International Scientific Conference and Quality Convention 2020.
May I request you all please use your mask which is provided in your bags and maintain social distancing. We shall commence today's opening ceremony with recitation of the Holy Quran. I request Dr. Najatullah Safi to recite few verses from the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم من أجل ذلك كتبنا على بني إسرائيل أنه من قتل نفسا بغير نفس أو فساد في الأرض فكأنما قتل الناس جميعا ومن أحياها فكأنما أحيا الناس جميعا ولقد جاءتهم رسلنا بالبينات ثم إن كثيرا منهم بعد ذلك في الأرض لمسرفون إنما جزاء الذين يحاربون الله ورسوله ويسعون في الأرض فسادا أن يقتلوا أو يصلبوا أو تقطع أيديهم وأرجلهم من خلاف أو ينفوا من الأرض ذلك لهم خزي في الدنيا ولهم في الآخرة عذاب عظيم. صدق الله العظيم. Translation. Because of that, we ordain for the children of Israel that whoever kills a person, unless it is for murder or corruption on earth, it is as if he killed the whole of mankind. And whoever saved it, it is as if he saved the whole of mankind. Our messenger came to them with clarification, but even after that, many of them continue to commit excess in the land. The punishment for those who fight God and His messenger and strive to spread corruption on earth is that they be killed or crucified, or have their hands and feet cut off on opposite side, or be banished from their lands. That is to disgrace them in this life. And hereafter they will have a terrible punishment. Sadaqallahu al-Azim.
May I request distinguished guests, participants and colleagues to rise for the national anthem.
Ladies and gentlemen, today's conference is one of the vital milestones FMIC has laid. We have previously organized 9 annual international scientific conferences and 9 quality conventions. Today, we are here at the 10th FMIC Annual International Scientific Conference and Quality Convention under the theme Universal Health, Accessibility, Quality, and Research in the era of COVID-19 pandemic.
This conference offers a unique forum for healthcare providers in Afghanistan to learn about current and innovative modalities and trends in healthcare, academics, and research at local, regional, and international levels.
We have arranged an exciting technical program comprising of scientific sessions and poster presentations, incorporating a wide range of topics. The inclusive topics are communicable diseases and global outbreak of COVID-19, public health and non-communicable diseases, nursing, midwifery, quality, and patient safety.
To begin the ceremony formally, I request Mr. Lee Hillen, Chairman FMIC Board, to present the welcome address. Mr. Chairman is with us online. Over to you, sir. Dear IT colleagues, please facilitate.
Thank you very much. It is my great pleasure to be with you. I would like to begin by welcoming prominent guest, distinguished gathering who is participating in this program with us today. Your Excellencies, Dr. Ahmad Jawad Osmani, Minister of Public Health, Mr. David Martinon, Ambassador of France in Afghanistan, Mrs. Shahrazad Hirji, Diplomatic Representative of the Aga Khan Development Network in Afghanistan, Dr. Eric Sasson, President La Chaîne de l'Espoir, and our noted keynote speakers, Professor Adil Haider, Dean of the Medical College, Aga Khan University, and Dr. Arshid Arzarine, Senior Radiologist, La Chaîne de l'Espoir. I also want to acknowledge and welcome and make note to Mr. Aziz John, Tara Bar-Ali, and others on the FMIC team who have organized this event. I am delighted to see the participants in the room that I'm looking at there. I trust you are all practicing proper protective measures with your mask, and it's a pleasure to see the interest that in the midst of this pandemic that this conference has drawn. It is my pleasure and my honor as chairman of the board of the French Medical Institute for Mothers and Children to welcome you to this 10th Annual International Scientific Conference and Quality Convention. I want to begin by acknowledging the challenges that Afghanistan's leaders have faced in 2020. You have confronted an historic pandemic, economic uncertainty, and increasing insecurity and terrorist attacks on your people and your institutions. Thank you, and God bless you for your steadfast courage and your will to work on behalf of your people. What an unusual time we live in, how disrupted our lives are. Many of us, along with those we care about and love, have suffered sickness caused by coronavirus, and many have died. Our daily routines and our livelihoods have been impacted in order to fight the coronavirus. Many have lost their jobs or their incomes due to economic shutdowns. But despite these sad things, these tragedies, life must go on. Hospitals must continue to care for the sick. Those who can work must forge ahead to keep our societies working and our services functioning. During these past months, I, along with other members of FMIC's board, have had the privilege to work with the management of FMIC to explore ways how, in the midst of this pandemic, the hospital can continue to care for those who depend on its unique service, and to explore ways that FMIC can support the government of Afghanistan in providing essential COVID-19 testing and care to Afghan citizens, and training and education during this pandemic, and to ensure that FMIC's frontline healthcare workers and those they serve and care for have been properly protected and working in safe environments. We are confident that FMIC has risen to the challenge in all of these cases, and I extend my gratitude, my deep appreciation to all of you who have performed with bravery and resilience during these trying times. As was noted earlier, FMIC held its first scientific symposium and quality convention in 2011. The purposes of these events were to provide forum for Afghans to share your innovative approaches to ensuring quality of services and to engage in critical thinking with your peers in Afghanistan and around the world. I believe these programs have accomplished that. Each year, several hundred local, national, and international participants have joined. By now, the number of participants has reached into the thousands. This year, FMIC's management was faced with the choice of whether, because of the pandemic, to cancel these critically important events. I am pleased they rejected that choice and committed to find a way to continue them. For reasons of efficiency and economy, this year they chose to combine the two events, the Scientific Symposium and the Quality Convention, that would have been normally held separately. And this event was organized substantially through the use of telecommunications, which makes the best use of technology of our time, and as a result, once again, gives hundreds of individuals the opportunity to exchange knowledge and ideas. The theme for this year's combined event is Universal Health, Accessibility, Quality, and Research in the Era of the COVID-19 Pandemic. There you go. That theme puts the challenge before you. Don't let this crisis pass without reflecting on what you have learned from it, without analyzing it and dissecting it. I look forward to the information that will be presented in today's program. I express my gratitude to all of you who refuse to let the virus defeat you, who will use this opportunity to engage in critical thinking and new learning. I am told this conference will be attended by more than 350 international and national delegates from different locations and from various countries, and including students, doctors, nurses, allied staff, and others. That is truly remarkable. I will close my welcoming remarks by sincerely assuring all of you in Afghanistan that FMIC's international partners and those of us from around the world who work with them continue to stand by you during these uncertain and unstable times. Please know that we believe in you and that we are honored to do whatever we can to support you in forging your better future. Good luck in your program today. Thank you. Shakur.
Thank you, sir, for a very comprehensive welcome address. And now, I take the privilege to ask Dr. Abdullah Fahim, Senior Advisor, Ministry of Public Health, to virtually read the message from Dr. Ahmad Jawad Usmani, Minister of Public Health, Afghanistan, who was unable to attend today's ceremony. May I ask the IT team to assist and connect me?
Sorry for the inconvenience because of some technological problems. Excellency, the Minister of Public Health has left Kabul for an urgent mission to one of the provinces. I, Dr. Abdullah Fahim, Senior Advisor, Minister in International Affairs, will deliver a speech to this distinguished event. Excellency, Ambassador Shahzad FG, Canadian diplomatic representative in Afghanistan, dignitaries from diplomatic community, government ministries, professionals from the Al-Khan Development Network, public and private health sectors, civil society, and distinguished FMIC board and FMIC team. Assalamu alaikum and a very good morning. Today, we all are witnessing a historic movement and historic moment as we open the 10th FMIC International Scientific Conference and Quality Convention. It's historic for many reasons, but two of those are very important to highlight First, it is a decade of constant efforts and collaborative work to promote the culture of scientific research and intellectual inquiry in the field of medicine. This untiring journey of FMIC and its partners is a remarkable achievement which not only promotes evidence-based knowledge, but also showcases Afghan health professionals' high capacity of innovation. Second, this event displays our strength and resolve to combat the devastating and unprecedented COVID-19, which has shattered economics and health system across the globe. I am glad that the theme of this conference also includes COVID-19, which demonstrates the relevance and timelines and timeliness of our intellectual endeavor. Hence, for completing a decade of relentless efforts and giving patronage to an intellectual and scientific journey, cultivating and disseminating evidence-based knowledge, and for successfully conducting the 10th International Scientific Conference and Quality Convention, despite challenges posed by the epidemic. I congratulate the entire FMIC team and all those who have made significant contribution to this drive over the past 10 years. I also understand that in April 2021, FMIC will be celebrating its 15th anniversary, which is going to be yet another milestone in the history of this amazing institution, which belongs to Afghanistan. I would like to congratulate FMIC partners, governance, and management for their relentless service and dedicated efforts towards improving the healthcare system in Afghanistan. I do appreciate the participation of such a large number of national and international participants in this conference, which shows their admirable commitment towards learning and sharing their wealth of knowledge, despite the uncertain safety and security situation in the country. The extraordinary participation of healthcare providers from across Afghanistan and other countries shows that FMIC conference has become a key event in the region amongst the healthcare fraternity. This is a great sign of Afghanistan in general and the healthcare sector in particular. The theme of this conference is Universal Health, Accessibility, Quality in Research in the Era of Invention, as a separate event, which provides yet another platform to share lessons learned from various interventions by healthcare professionals in a drive to improve quality of services at hospitals across the country. This year, due to the pandemic, the Quality Convention has been combined with this conference, which is yet another sign of our resilience. Afghanistan was hit by the pandemic a critical find in the peace process. Despite all those challenges, we have fought together, but the challenge is not over yet. We need to show more strength and power to reach the new normal. Afghan healthcare system has come a long way over the past decade to tackle these issues and have seen improvement in many of its services, both at rural and urban levels. This is evident when we see the health indicators have improved, especially related to the mothers and children. However, despite these successes, we see many challenges remain, and these can only be solved if we join hands and support each other. One of the greater challenges is access to high-quality healthcare services and ability of well-trained doctors and nurses needed for our country. At this conference, we will have sets of scientific presentations which I am sure will add to our knowledge. This serves as an opportunity to share the good with all stakeholders, create awareness about our achievements and the way forward, share evidences of best practice, and reaffirm our commitment towards the implementation of the Sustainable Development Goals, so that no one is left behind in the society to enjoy a healthy life and well-being. Once again, I congratulate the FMIC team for their amazing work despite several challenges. I salute the researchers, academicians, and healthcare professionals for their generosity of knowledge and scientific endeavor for excellence. Thank you for a successful conference.
To have with us virtually connected our distinguished guest, His Excellency Mr. David Maftenom, French Ambassador to Islamic Republic of Afghanistan. Your Excellency, we are privileged to have you with us today. May I request you to kindly enlighten us with your thoughts.
Dear Sherazad, dear Lee Hilling, Chairman of FMIC Board, dear Cher Eric, dear Eric Chesson, President of La Chaîne de l'Espoir, ladies and gentlemen, I am of course happy and honored to be with you today, even if it is virtually. The theme of the conference could not be timelier and more relevant. We are entering a new era with this global COVID-19 pandemic that directly or indirectly affects every human being on this planet. Who knows how much our lives will be changed because of this disease in the future. This is why scientific research is so important in order to prevent or contain diseases of all kinds, which doesn't know borders nor regulations. This is also why we can't play alone, and therefore we have to maintain and enhance networks, and we need to work together. This is why France has decided to keep on supporting the World Health Organization, and notably its vaccination programs for the poor countries. And this is also why France tends to consider the next vaccines as a public good for the world. In this regard, FMIC is a good example of this working together, given its unique partnership which gathers two governments, an international organization, and the French NGO. And we French people are very proud to be part of this adventure. We are on the verge of celebrating 100 years of relationships between France and Afghanistan. And I would just like to take 1 minute to recall the time in the 1930s when the first Afghan students coming from Istiklal High School were able to join the faculties of medicine in France. And then in the 1960s, the Faculty of Medicine and the Faculty of Pharmacy of Lyon, which is a provincial capital in France, decided to create a link with the University of Kabul to give the opportunity to tens of young Afghan physicians and pharmacists to attend courses given by French professors before even going to France and getting specialized. I would like, of course, to recall what happened in 2002 when our friend Professor Eric Chesson, one of the most famous French doctors, realized while he was coming to perform surgeries how huge was the lack of medical infrastructures, devastated after 40 years of construction. And he was the one who convinced us to think bigger and to build jointly with our dear partners what will soon become the best hospital in Central Asia. For the French government, this hospital is a long-term project that requires continuous involvement, and it holds all its attention. We signed an agreement in 2006 for 24 years, and we will closely, like a mother on her child, follow its improvements and achievements. Yesterday it was phase 1 and phase 2. Tomorrow it will be phase 3. Recently, at the height of the pandemic crisis, the President of the French Republic, Emmanuel Macron, decided notably to grant FMIC 1.7 million euros in order to enable it to face the pandemic crisis and to continue its mission of treating patients. Regarding research and development, the reason we are together today, I would like to convey a message and express a wish. First of all, as I said in the beginning, developing networks, sharing information and working together are essential to fight against disease, which spread and mutate without any notice. And therefore, your mission is also to knock on the door of the other scientists and to ask them what's new, how can we help, have you seen this? And this is why I urge you to connect with the French researchers and develop projects in common. Second, I wish that for the coming conferences, my successors here will have the pleasure of bidding welcome to French specialists who will be renewing, by doing so, a tradition of friendship and cooperation between France and Afghanistan. I wish you all a fruitful conference and I thank you.
Ladies and gentlemen, it's a great privilege to have with us virtually connected Her Excellency Ms. Shahrzad Hirji, AKDN Diplomatic Representative, Afghanistan. Your Excellency, we are grateful to have you with us today. May I request you to kindly enlighten us with your thoughts. Over to you, Your Excellency.
Assalamu alaikum. I just want to make sure you can hear me fine.
Yes, we can hear you.
Excellent. Excellency Marquinhos, Lee Killick, Chairman of the Board, Eric Chasson, Chairman of La Chaîne d'Espoir, Dr. Abdullah Fahim, on behalf of the Government of Afghanistan Ministry of Public Health, Dean Adil Haider, AKDN and AKU colleagues, distinguished guests, ladies and gentlemen. Thank you so much for the opportunity to join you virtually. I would normally be in Kabul with you, but I'm actually back in Canada for a break. And it's a real privilege to address all of you. Much has been said about what we are going to be doing here today and the importance of this particular conference at this particular time. I'm going to try and situate FMIC a little bit in the context of the broader work that AKDN does in Afghanistan. In all of our social, cultural, economic activities, healthcare features largely, and it features through FMIC, which is our main, I would say, footprint in Kabul, but also through the Sehat Mandi, where we have responsibility for Bamiyan and Badakhshan through Aga Khan Health Services. And what AKDN is generally known for, whether we do it in Kabul at FMIC or whether we do it in the provinces, is a few things. Number one is quality. We're known for connecting local to global, to make sure that every country where we operate, we provide, we enable, we support access to global level knowledge, healthcare, around healthcare, and help to improve the systems. So in FMIC's case, for example, it's not just about one hospital, but it's about the system that we are helping to support. And this year particularly, we work closely with the Ministry of Public Health on their hospital improvement program, for example, hospital management program, to be able to infuse some of our global expertise into what is happening locally in Afghanistan. That's one thing we are known for. The other thing we are known for, which I think FMIC exemplifies in Afghanistan, is partnerships. We leverage partners, whether they are knowledge partners, whether they are financial partners, whether they are volunteers in our system across the globe. And it's really important for us to be able to leverage all of those resources to benefit FMIC, to benefit the work that we do in Afghanistan generally. But I think it is a real privilege that we have our partners from La Chaîne d'Espoir, from the AKU, and the government, as well as from the government of France and Afghanistan, both governments with us. Because I think it's this partnership that sets us up, as Excellency David Martino said, for future success and looking long term to build the kind of healthcare system we need to build in Afghanistan in the future. And so it's a real privilege to do that. I also want to just remind us of a couple of things. Even though FMIC is based in Kabul, we actually serve patients from every one of the provinces in Afghanistan. We serve children and families from Kandahar, from Ghazni, from Herat, all over the 34 provinces. So our reach as FMIC is extremely wide, and I think that is reflected this morning in our reach to be able to access and share knowledge, because we have people from all over the country, but also internationally as well joining us. And so we're very, very privileged to see FMIC's reach broaden much, much, much beyond Kabul, certainly, and now starting to broaden beyond Afghanistan's borders as well, because Afghanistan has a lot to share when it comes to knowledge that is being created at FMIC. So that is a real privilege. Over the last many years, we have served over 1.6 million, I think 1.4 million patients. And of the almost 1,000 employees, 27% are women. And of the managerial positions, 21% are women. And so again, a part of capacity building is also building and investing in women's leadership in Afghanistan. And we're very, very pleased to see that that is something that we are very much a part of. I will also mention, because I think it's important, as FMIC, we try and be leaders in as many ways as we can, so that we can set a standard, we can help others in healthcare in Afghanistan start to achieve those standards as well. When I look at some of what FMIC has achieved, we were the first to perform open heart surgery in 2006. We were the first to successfully launch a telemedicine program in 2007, which to this day benefits thousands of patients across Afghanistan. We were the first we had the first Afghan cardiac surgeons who performed closed heart surgery. That was in 2008. And I can go on. We were the first ISO certified hospital in Afghanistan. We had the first 128 slice CT scan. I can go on and on about the firsts, but they're important. We were the first to successfully separate co-joined twins at birth in 2015. And the reason for raising those is to say that Afghanistan is doing a tremendous amount of work in healthcare, even though we have a long way to go, FMIC's history over many years. And I think together we are set up to succeed. We are also on our way to work towards the Joint International Health Commission certification, which again would be a first in Afghanistan, and would again show the kind of leadership that Afghanistan can show in healthcare. So we have a lot to look forward to with FMIC, as FMIC, and with our partners. And so I think for this morning, we look forward to an excellent morning of learning, of sharing knowledge, and of building knowledge collectively amongst us, but amongst a broader group of people as well. I will wrap up my remarks there to wish all of you and to thank the management for excellent work through a very difficult year. As a board, we were meeting every week for a long time, sometimes twice a week, to help FMIC come through COVID, working in partnership with the government and others around the table. So it has been a difficult year for FMIC, as it has for most healthcare systems. And really, congratulations to the management and the teams at FMIC for helping us through the year. Fantastic morning, and I look forward to following the conference for the rest of the morning. Thank you.
Ladies and gentlemen, we have a recorded message from Dr. Eric Chesson, President La Chaîne de l'Espoir, who was unable to attend the ceremony in person. We request our IT team to play the video message.
Your Excellencies, dear colleagues, dear friends, it was very important for me to address you a short message during this important conference. A message of friendship, a message of solidarity. It has been exactly 1 year since I have not able to come to you. We are all going through very difficult times all over the world. The pandemic has impacted all the countries. Believe me, I miss you. I look forward to meeting all of you in the near future, I hope. Be sure that my heart and soul are in Kabul with you right now. Coronavirus has increased mortality and reinforced the disparity in access to quality healthcare for the most vulnerable. The respect of barrier gesture is difficult to these people who often lack the financial means in order to buy masks, gel, and so on. Furthermore, most of them have no choice but to work, even in conditions that do not allow them to protect themselves from the virus. We need to act. Since the beginning of the health crisis, the FMIC has made itself available to treat, control, and cure coronavirus disease. At last, FMIC can be proud to have kept providing access to essential and urgent healthcare during this crisis. Again, congratulations to all FMIC staff, medical and non-medical, for your work during this crisis, which has made it possible. La chaîne de l'espoir could organize only a few missions for several months, but I've organized a lot of video conference with FMIC medical teams in order to train on COVID and other medical topics. FMIC partners have supported the hospital, in particular financially, in order to help the most vulnerable Afghans. La chaîne de l'espoir has provided an additional 500,000 euros to the welfare funds. His Highness has also made a remarkable financial contribution of $1 million. Finally, the French government has provided an exceptional financial support to FMIC with 1.5 million euro additional contribution. We are all in this together, and I believe solidarity is the key. Zoom, WhatsApp, Snapchat are very nice. They are very useful numeric tools, but it will never replace human contact, face to face without mask. I hope from the bottom of my heart to be with you, by your side. I hope in March for the next board. And I repeat, I miss you. I miss Afghanistan. We have to know that the commitment of La Chaîne de l'Espoir for FMIC with our partners remains intact, whatever the difficulties. Take care of yourself, take care of your family.
It's a great privilege to have with us today Dr. Adel Haider, the Dean of the Aga Khan University Medical College and Professor of Surgery and Community Health Sciences, as a keynote speaker for this conference.
Excellency, Mr. David Martignon from France, Your Excellency, Mrs. Sherzad Hirji from AKDN, of course, Mr. Lee Hilling, Chair of the FMIC Board, Mr. Abdul Tawab Barali, the Chair of the Scientific Committee, my good friend, Dr. Shafiq Mirzazadeh, and Mr. Aziz John, CEO of FMIC. But most of all of you there in the audience, especially those standing in the back, I want to say good morning and thank you for giving me this opportunity to speak to you today. I particularly want to thank any of the trainees in the room. Recently, I had the opportunity to interact with several of the FMIC residents who are in Karachi right now for their rotations at Afan University Medical Complex in Karachi. It is such a privilege to meet all of you, and I am always inspired by the incredible work you do at FMIC. I personally have wanted to visit FMIC and am waiting for the opportunity to get there. So before I begin, I want to give each one of you a round of applause for the amazing hard work that you have done. Please give yourselves a round of applause. My message today is one singular message, and that is how we must build our systems stronger. But the way to build these stronger systems is to build resiliency in our people. Now, today we're having this great scientific conference, and it's the quality conference as well, and it makes sense. You know, I speak with the FMIC colleagues all the time, especially Mr. Aziz John and all of the colleagues there. They're always talking about improving quality. All the board reports are about improving quality. And if you go back to kind of the very basic thing that we've known, is that it's all about structure, process, and outcome. Everybody knows, I'm sure here in the conference, about the very famous Donabedian model that we've all heard about, in which you talk about the environment in which the care occurs, how that impacts how care is delivered, and then how that eventually leads to improved outcomes for a population. Everybody's heard of this, right? Donabedian model, people have talked about this forever. And if you really drill down into it, you think about how the people, equipment follow a structure, how that you add some policies and processes, and I'm sure at FMIC you have all sorts of policies that create the process, and that how this all together leads to an organizational culture that delivers great patient outcomes. In fact, the next iteration of this is what's called a learning healthcare system. And this is the recent work that I was involved in with the National Academies of Medicine back when I used to work in the United States, where we talked about creating a national trauma care system, and we had the audacity to say that we could create a system in which there would be zero preventable deaths, that our system would be so strong that there would be nobody who died for reasons that we talk about, for example, at M&M and so on, that there would be no mistakes, that the system would be so strong that there would be no mistakes, and that these learning healthcare systems would be the panacea of everything. That, you know, you would have, and I know FMIC is very excited about getting their electronic health record, but you would have this electronic health record, you know, you would have the health record for one big practice, then you would add the health record for one large population, that health record based on what medicines we're giving and how the outcomes look would eventually improve clinical guidelines, change public policy, and eventually you wouldn't even really need to be so smart as a doctor or nurse, that there would be clinical decision guideline support, CDS, in your electronic health record that would tell you what is the best medication for any patient. So this is how we were going. And you know, I myself have written, you mentioned the number of publications that I have, I myself have written countless grants and many publications in which I made the mistake of saying that the system was more important than the individual. I will be here with you today to say COVID has completely changed my opinion on this. How has it changed the opinion? You know, when COVID hit us in Karachi, we did what anybody would do we did tabletop drills, right? We said, okay, you know, the COVID's gonna hit us. We set up a hospital incident command system. We tested our responses. We even changed who the leaders are so that, okay, maybe, usually it's the CEO and the dean together co-leading this, but we're like, okay, we'll just get anybody in there and they'll lead the system and see how it'll work. And we'll be like, great, the system works perfectly. It doesn't even make a difference who's really in that system. And we prepared and we rehearsed and we were pretty sure that when COVID hits us, we're going to be just fine out there in Karachi. But then COVID hit. And all of you are, of course, going through this with us as humanity together. This is how COVID looks today, right? And we are in Karachi, much like the rest of the world, suffering from what we're calling a second surge. We're very grateful that at this point in time, rather than the graph keep going up and up and up, there is some halt on the graph, but who knows if it will go back further up. But that's where we are today, 8,900 deaths. And of course, we've had significant disruption to our healthcare system with all of this. Now, back when COVID initially hit us, there were several problems, but 3 of them were very important. The first was what to do with all those patients. We had hundreds of patients lining up at our door, all worried that they might have COVID. They wanted to be tested, they wanted to be treated. Where were we going to put all these patients? On the one hand, we had hundreds of these patients. On the other hand, because of a lockdown in the city, the rest of our patients had disappeared. And then, where are we going to put these patients? Especially patients who tested positive. We did not have the resources and ability to take care of those patients, and especially, we did not have the ability to safely take care of those patients in a way that would protect our healthcare providers. Now, I'll tell you, remember, I thought that our system and our tabletop exercises would just take care of everything. But my friends in Afghanistan, just like I'm sure you must have felt, those systems that were designed, while very, very valuable, were unable to respond in a way that each one of us would have hoped they would have responded. And so our real learning was that it was actually the people on the ground who made the difference. There was no amount of telecommunication technology or a device or anything like that that could help us more than the smart ingenuity and the intelligence of the people who were there providing care, who made all the difference. And so today I want to submit to you that more than the system, it is the people who make that system strong. And that over the years, this paradigm that we have begun to say, that the system is more important, I want to bring us away from that. And I'll tell you, I have always been a big champion of this. You know, I'm a trauma surgeon. We used to be in a rota system where, I would work 24 hours as a surgeon, and then I would just hand off to whoever took over, and the system should be able to just keep working. And while that does work, it always regresses you to the mean, and when you get a curveball like COVID, it's impossible to make a difference. Now, when this thing did hit us, we realized we needed to impact COVID at a variety of different levels. So first is that we had to be part of the national conversation in Pakistan, and many of our experts were out there advising the government on a variety of different ways. And without actually having an impact with the government, we could not impact this large medical center that we have. And then we had to ask different groups to step up and do something that they've never done before. I happen to be a surgeon, and you might think that the surgeons really are ahead of everything. But turns out that the department that did the most incredible work was actually the Department of Family Medicine. Because family medicine is where occupational health resides. Family medicine is where all the screening and taking care of patients and our own people occurred from. And they ended up doing the most incredible work. Like, for a surgeon to say that the department that I am the most inspired by happens to be the probably least funded department, the department that makes the least margin at all in the hospital, family medicine. But they were the saviors for us throughout the whole COVID thing. We created this whole testing zone where we have now tested more than 200,000 patients. Family medicine is doing an incredible number of teleconsults to manage all these patients. I mean, it's just remarkable what those people do. There was no system that put family medicine as the group that was in charge. The other big issue was how do you take care of patients who are acutely ill? And what about those patients who immediately are coming into the emergency department complaining of respiratory distress? We have to work with our colleagues, and this is where I'm so inspired by them, in facilities who literally overnight created negative pressure spaces for us. Again, there was no system. I mean, there was some mass casualty management system that we were using, our command system. And in that command system, there was this idea that the facilities group would be able to respond to things, but there was no definition of exactly how they would respond. And it took individual ingenuity. It took the facilities people, it took the service line chiefs of the emergency department to go look at what they had right down here and then put it into a negative pressure situation. And then, of course, we ended up devoting an entire building, which used to be our old private wing, to COVID so that we could then isolate all the other patients in the hospital. You see, it was so important to get the hospital to run with all the other kinds of patients, so that we dedicated one specific building for COVID so that the rest of the hospital could always run. And then we had to create backup. So we have a beautiful simulation center. We created a backup system in that, and then a further backup system in our gymnasium. All of these things there were some plans about these things. But again, without the people on the ground, we could have never ever come up with them. And then as we were able to bring back our students, we had to come up with ingenuitive ways of how we're going to manage them. So for our students, we actually created what we called academic bubbles, where to enter the bubble, you had to actually get a tick mark on your cell phone. We have this little app, it's called Sehat Check. And that asks you 4 or 5 questions about your exposure, how you're feeling. Make sure that you don't feel like you have symptoms of COVID for that day. And when you show that app, then only you can enter into the academic spaces. And then we had to continuously update our PPE guidelines so that we could help all of our people. What I'm trying to say is that all these decisions that were made were made. Yes, we had a system, this Hicks command system, but within that system, we needed to empower resiliency within our people to be able to make a difference. And so in the post-pandemic world, and I know my remarks are very brief, and I'm happy to give more details later, this is what I think this system needs to look like. I think we need to, as leaders, the structure needs to be set up where we understand every single person must have training in how quality is delivered, so that they have the basic understanding of how this is done. And then we must empower the leaders at all levels. You see, what happens right now is that we have a group of very senior leaders. These are the senior leaders that interact with international partners and so on. But then the people who are actually on the ground in the middle of the night making those difficult calls, they are not those people. There's a disconnect. And what we must do is that we need to strengthen this middle level, the people who are actually providing the care on the ground, the nurse managers, the assistant managers. Those are the people that need to be empowered so that they can make adaptations, and more importantly, that they can take risks. You see, the thing to understand, and this is especially for our international partners, when we work at these multinational organizations here in Pakistan, Afghanistan, other places, these are great jobs. Things are going to change. This is how our class looked when we started, and this is how our students look today. Thank you so much, and I wanted to end with inviting you to our 25-year PGME ceremony later this week. On Saturday, we've had 25 years of experience with PGME. We love having the PGME students from our trainees from Kabul, and look forward to seeing you at this event as well. Thank you so much.
Now, I would like to request Mr. Abdul Tawwab Tawab Baryalai, Administrator Quality and Patient Safety and Chair Scientific Committee, to brief us about the program and objectives of the 10th FMIC Annual International Scientific Conference and Quality Convention.
Thank you. Bismillahirrahmanirrahim. Your Excellencies, honorable colleagues, fellow researchers, distinguished guests, ladies and gentlemen. Assalamu alaikum, good morning and bonjour. On behalf of Organizing and Scientific Committee, it is my great pleasure to welcome you all at the 10th FMIC Annual International Conference and Quality Convention. As rightly mentioned by our chairman, since year 2011, FMIC organized its annual international conference and quality convention. Each event was celebrated separately. This year, FMIC has combined both the event together in response to challenges posed by COVID-19 pandemic. Initially, we planned that this year conference will be held on November 7, 2020. But due to some unavoidable situation, we postponed it today. So we are here physically and virtually today to celebrate this event. The theme of this year's International Conference and Quality Convention is Universal Health, Accessibility, Quality, Research in the Era of COVID-19 Pandemic. The theme and sub-theme of this year's conference is driven from World Health Day and other global health agendas. So, the purpose of the 10th FMIC Annual International Conference and Quality Convention is to provide platform for the researchers, scientists, academicians, government officials, policymakers, physicians, nurses and midwives, and other healthcare professionals to discuss issues, evidence, and measures related to accessibility, quality, research in the era of COVID-19 pandemic. Distinguished guests, ladies and gentlemen, FMIC management decided to conduct this event under new normal situation. It took us almost 2 months and 10 days to make all these arrangements. Let me brief you on the process undertaken. In a very limited time, almost 1 month, we have received 76 abstracts from our national and international researchers. Out of all these 76 research papers, 32 were selected for oral and 38 were selected for poster presentation. Out of these 76, 6 abstracts were not considered for this international conference because they were not meeting the established criteria by the scientific committee. Ladies and gentlemen, we have provided you a 4-page document in which detail of the overall conference and sessions are provided there. So you may look on that. So our first session will be on communicable disease in global outbreak. It will be started at 10:30 a.m. and will continue till 12:30 p.m. And we will have almost around 15 presentations. But I'm saying almost because some people may not be able to attend. Our second session will be on public health and communicable disease. The session will start after lunch break. It will be from 1:30 to 3 p.m. So it will be 90 minutes and we will have 10 presentations in this session. Our third and final session will be on nursing, midwifery, quality and patient safety. This session will start after tea break at 3:15 p.m. and will continue till 4:25 p.m. And we will have almost around 7 presentations in this session. So the program will be brief and closed by the closing remarks of our CEO. Ladies and gentlemen, our posters are displayed outside this auditorium under the Shamiana. May I request you all to please have a look during lunch and tea break. The posters which are displayed there will be evaluated by the group of juries, and we will announce the 3 best winners by the evaluation of these 3 juries who will be evaluating all these posters. I hope that we will all have the excellent opportunity for exchanging the information during these sessions. Once again, I thank you for attending this academic event. Have a fruitful learning and productive days. Thank you, Manana Intashkar.
Ladies and gentlemen, I request you to kindly join us for the refreshment arranged outside. Serve yourselves and enjoy.
Every presenter to please limit their presentation to 7 minutes, and all other colleagues participants they can note the questions, and we will have a few minutes toward the end of the session to discuss the points that require more clarification and correspond to the questions that colleagues may have. So we will start the first presentation. The presentation is on epidemiological analysis of acute vaccine paralysis in the southern region of Afghanistan. The presenter is Dr. Sattar Amanzak. He is the graduate of Free Epidemiology Control Program, and he is moving for AP surveillance in the southern regions. Dr. Amanzak, please, the floor is yours.
I would like to present my study epidemiological analysis of acute placid paralysis in southern region of Afghanistan 2016-18. Significant progress has been made during past years in polio eradication program. In cases in 2019-88, the total cases were expected 35,000 cases estimated, compared with the 21 cases in 2018 globally. Endemic countries number is reduced from 125 in 1988 compared to two countries, Afghanistan and Pakistan in 2018. AP is a clinical syndrome that characterizes sudden onset of weaknesses or lumps. This presentation describes the epidemiological distribution of AP cases in southern part of the country. The delay specimen arrival to lab in the region AP surveillance database. Specific intervention is need to improve the routine immunization coverage. AP surveillance database information need to be completed per individual case. Further study have to be designed to identify the line case of the zero OPV children and routine immunization in SIS. Thank you, all of you.
Thanks, nice presentation.
Okay, thank you, respected the chairman of this scientific conference and all participants, and also our respected previous director, Dr. Najullah Safai. And also Dr. Isam said that they were previous our leaders and our responsibles. We appreciate their management and good memory with them. So my presentation just in cascade bit analysis of the program, and the program for the National AIDS Control Program for hepatitis in Asia.
In 2012, 31 female was newly detected, but in 2019 it is increased in 9.1% compared to the few years before. It was at the beginning in the 2012 31 cases, but in 2019 it was 57 cases. It is increased from 19.1% to 29.6%. And also the age was for the female 20 up to 29 age of years, and also for the male it was 39 for the period of 2014 up to 2019. And also there was, during this period, there was 751 new HIV diagnoses. In 2021, we will be conduct this survey and the prevalence will be determined. Thank you.
You have a good presentation, and still HIV is a big concern in Afghanistan. Even we have low number, but still it's a big concern. Thank you. If you have questions, you can note at the end of speech. Thank you.
Thanks, Zakariya. Our next presenter is Dr. Muhammad Basir Hamidi. He is graduated from Nangarhar Medical University, and currently he is the program manager for AIDS, hepatitis, and STI. He has diverse experience of working with government and non-governmental organization. He will be talking about mapping and population size estimates of people who inject drugs in Afghanistan. Dr. Hamidi, the floor is yours.
Assalamu alaikum. On permission of the chairperson of this conference and my dear colleagues who participated in this meeting. Today I will discuss about the mapping and population size estimation of people. PWID population sizes considerable in certain area of country. A large number of them are infected with HIV and need to be reached for care and treatment service in Afghanistan. Thank you for your attention.
Thanks for some nice presentation and highlighting the importance of this critical problem in Afghanistan. Injecting drug use is a major problem, and if we see one of the studies conducted a few years back, it estimates that around more than 3 million people in Afghanistan they are engaged in using different type of drugs, and a portion of that is using injection, which is a high risk for HIV. So thanks a lot, and thanks for being within the time.
Assalamu alaikum to everyone. I would like to present child immunization coverage survey in Kandahar province, which is done by Dr. Abdul Sattar and me. This is a provincial profile which you are seeing: population, districts, health facility with EPI centers, city populations, urban health facilities, and private health facility in Kandahar province. This is Kandahar province map, and signed it by NSR sentinel sites with their reporting disease. Sentinel sites saying they are reporting weekly disease. So, introductions. Immunization is the most cost-effective public health events due to averaging and estimated 2 to 3 million deaths every year. In Afghanistan, the immunization program started in 1978, named Mass Immunization Program. In 2003, the immunization program included in structure of the Ministry of Public Health. Currently, the EPI program applied 13 vaccines against 10 childhood disease. In this slide, we can find many different variables, but here in Pinta 3, Pinta 1, and measles 1, we find lowest percentage, 19 and 32%. We have the coverage of the Pinta 3 and measles 1. In this factor associated with full immunization, immunized children, in this slide where we go, if mothers have a high educated mothers, their children will
be, you have only 1 minute.
100% they vaccinated their child. There is top 5 reasons we analyze in the survey to find the gap of the non-vaccinated children. This is the trend of survey with the Afghanistan Health Survey and API coverage data, administrative data, and this is the survey line of our APTP survey. Challenges was card was not available with families, low awareness of community, low coverage of all antigens compared to national level target, high drop-off of Pinta 1 and Pinta 3, measles and BCG. Mothers did not aware about the next dose of the vaccinations, rumors against vaccination program. Mothers did not allow for children vaccination by family, low capacity of EPI staff, and lack of follow-up the defaulters. Weak outreach activities. Conclusion, more female children are fully vaccinated compared to the male children. Full immunization children number is less. Measles validity not acceptable. Coverage, caregiver education has directly proportion with the vaccination coverage, full immunization. Most significant factors are low community awareness, no proper message for the caregiver by health staff. Recommendation to capacity building, the training for the EPI staff, need intervention of community awareness, community engagement and vaccination program, support, supervision and monitoring, established and strengthening mechanism for different defaulters follow-up, focusing and delivering EPI message to the child caregivers, and field survey for reported data cross-check. This is a acknowledgement which we are thanks for the MOPH, NGOs, our APTP, Dr. Islam. They are helping us to collect the data. Also, I would like to thank the collectors, mentors, that they are supporting us, and also the family, which they are answer to our questions and give their time to complete the survey. Thank you so much.
He is graduated from Kabul University, did specialization in pediatrics, and currently working as a pediatric consultant in FMIC. He will be talking about isolated microorganism from blood culture in FMIC. Dr. Jalazai, the floor is yours, please.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to share my work on 13-month study on isolated microorganisms from blood cultures on a sensitivity pattern in an admitted pediatric patient in a tertiary pediatric hospital. As we all know, bloodstream infection are important cause of mortality, morbidity, prolonged length of stay of patient inside the hospital, on heavy financial burden on the families. Among bloodstream infections, those infections which occur inside the hospitals are more serious because most of them are resistant to commonly used antibiotics. This is why having knowledge about the common causative agent of bloodstream infections on their sensitivity pattern is much important, not just for better treatment, also for prevention of this type of infections. Objective of my study is to determine the common causative agents of bloodstream infections on sensitivity pattern in admitted pediatric patient in FMIC, and to determine the expired rate from bloodstream infection in admitted pediatric patient at FMIC. Study design is a retrospective case series study. On study sample was admitted pediatric patient with positive blood cultures. Study period was 13 months, starting from 1st of January 2018 to 30th of June 2020. Other hygienic precaution is crucial to decrease the incidence of bloodstream infections. Also, for conducting a better study, we suggest to improve data record system in patient file, in medical record on infection control department. Also, we suggest to revise and improve blood sampling method for culture, use of antibiotic for sensitivity on blood culture reporting method. Thank you.
Thanks, Mr. Janazan.
Dr. Nabila has been working with FMIC dental clinic since 2015, and she is currently at the end of her graduation from Stomatology Hospital.
Honorable members, I'm Dr. Nabila. My supervisor is Dr. Muhammad Ahmed Al-Bushi, and I wanted to present my presentation. The title of my presentation is The Pattern and Proportion of Gingival Enlargement Among Afghan Pregnant Women between 20 to 40 years old in a Stomatology Hospital, Kabul, Afghanistan. And the background. Before I go to the part of the research, I wanted to describe a little bit widely because dentistry is a little bit different from the other divisions. So the normal predentium provide the support necessary to keep or maintain the teeth in function, which its composition of the three main parts: the gingiva, the predental ligament, and alveolar bone. Therefore, increase in size of gingiva is a common feature of clinical disease or enlargement. Gingival enlargement can be classified according to the etiological factor and pathological changes as follows. Inflammatory enlargement, it may be acute and chronic. Drug-induced enlargement due to taking of some medicine, maybe anticonvulsant, immunosuppressant, and calcium channel blockers. And conditional enlargement is in some patients who have hormonal changes, maybe pregnancy, puberty, and any other allergic condition, and immunity system condition like vitamin C deficiency and others, and systemic disease and others false enlargement. Introduction. During pregnancy, there is an increase in level of both progesterone and estrogen hormone, which by the end of third trimester reach level 10 to 30 times the level during menstrual cycle, respectively. These hormonal changes induce the changes in vascular permeability, leading gingival edema and increased inflammatory response to dental plaque, which in subgingival areas there is increase in Probatelia intermedia, which is a cause of the enlargement among the pregnant women. According to the degree of gingival enlargement, from grade 0 to grade 3, grade 1, grade 0 was the patient who didn't have any sign of the enlargement, and grade 1 enlargement in area of interdental, and grade 2 was the area of interdental and both marginals, and grade 3 which surrounds all quarters of the teeth. So in pregnant patients, 12 patients or 30% were in grade 3, and 9 patients or 22.5% were in grade 2 of gingival enlargement, and just 1 patient was in grade 1 of enlargement. Was common factors that observed among the study samples, and appropriate intervention is focusing on oral hygiene is required to prevent gingival enlargement among the pregnant women in Kabul city. A recommendation: awareness program for oral health, cyclic dental checkup, and declining of traumatic cases, and performing of scaling and root planning. Thank you.
Our next presenter is Naib Naik. He is a graduate of Kabul Medical University and pre-medical program. He worked in different capacities in different departments of the Ministry of Public Health, and he will be talking about AFP surveillance at the central region of Afghanistan. Dr. Naik, the floor is yours. You have 7 minutes.
So, welcome to FMIC International Conference. I would like to share my study, AFP Central Region, 2016 and 2017. Central Region consists 8 premises. Total AFP reported in 2016, 507, and in 2017, 70,535. Introduction. The introduction of my studies was of country eradicated polio virus, and only two countries, Afghanistan and Pakistan, remain endemic. So polio virus is a big challenge in MOPH. So Afghanistan is announced as the programs of emergency. So Afghanistan FP surveillance has been started on 1997. The objective of my studies to know the age suffering, to know the age group suffering from polio, to know the trend comparison of AFP case between 2016 and 2017, now the trend of AFP case between male and female. That I could not understand, missing the data was there, meet RI based on available vaccination card. Recommendation: strengthening of the surveillance system in the country, easy access to the surveillance data to all data users. AFP surveillance staff are be trained on the AFP surveillance data collection, data and database use. Need the special investigation for higher activity strengthening. Panjshir, Bamiyan, and Kapisa data have been cross-checked and should focus the surveillance system. Thank you, all of you.
Mr. Muhammad Mazim Fazal studied at the Nursing School of Global Institute in Ur province.
نهایت گرامی پرزنتیشن را که عمل کردم خود پرزنتیشن انگلیسی ولی اگر اجازه باشه من میخوایم شکل فارسی بکنم.
بفرمایید.
نقشه ولایت پور که همین ما شما میبینیم ولایت پور دارای 11 ولسوالیه و تعداد نقاط که ما سمپل جمع آوری کردیم و دسترسی عمومی ولایت پور. در که ما شما در جریان قرار داریم مرض کووید 19 در اواخر ماه دسامبر سال 2019 در شهر ووهان چین واقعات کشف شد. در جریان 3 ماه 199 کشور جهان را مسافر. اولین واقعه در 24 ماه فوریه سال 2020 به شهر هرات افغانستان ما شما کشف شد که مریض از ایران به افغانستان آمد. به خاطر ما به خاطر سیستم سرویلنس کار میکنیم، واقعات را جمع‌آوری میکنیم. استعدادی که ما انجام دادیم راجع به مرض کووید 19 در ولایت پور. نقشه ولایت پور و تعداد شفاخانه‌ها و مراکز صحی در ولایت پور فعالیت می‌کند. میتونید که ما استفاده کردیم به خاطر جمع‌آوری ارقام واقعات کووید 19 که استیفینیشنی که از طریق وزارت محترم صحت‌عامه به تمام ولایت توزیع شده بود. واقعات مشکوک نظر به جمع‌آوری می‌کردیم و بعد از تمام واقعات سمپل جمع‌آوری شده در سطح مرکز و ولسوالیت. واقعات جمع‌آوری شده، لندلیست شده و لابراتوار روان شده. بعد از نتیجه لابراتوار توسط سیستم SSB20 انالیز شده. نتیجه که ما به دست آوردیم از سری 1246 سمپل ما جمع‌آوری کرده بودیم که از بین 1246 سمپل 546 سمپل مثبت بوده که 43.0% واقعات ما مثبت جمع‌آوری شده واقعات که ما برگزار آن کرده بودیم. 45% واقعات مریضایی بوده که از مرکز ولایت جمع‌آوری شده. بیشترین واقعات از مرکز ولایت بودن. تعداد 63% مریضای ما مردها بوده و 33% خانم‌ها تشکیل بوده. 12.5% واقعات ما شفاخانه‌ای شده که به شفاخانه بستر شده. کیس فتیلیت ما 2.4% ترند امراض شکی که ما شما می‌بینید نظر به ولسوالی انالیز کردیم که در هر ولسوالی چند واقعه چند سمپل جمع‌آوری شده و چند فیصد از او مثبت بوده نظر به ولسوالی. در این سلات چیزی که ما شما می‌بینیم تعداد واقعاتی سمپلایی که جمع‌آوری شده نظر به سن سال یعنی خردترین سن و بلندترین سن. ما شما شکل می‌بینیم کمترین واقعات از اطفال زیر سن 10 سال بوده بیشترین از کسایی بوده که سن از 9 از 50 سال به بالا بوده. پیک مرض شکل که ما شما می‌بینید در جریان ماه جون و جولای بیشترین واقعات در ولایت بور داشتیم. یعنی شروع واقعات ما از ماه مارچ بوده، ما از ماه فوریه به این طرف سمپل جمع آوری می‌کردیم. اولین واقعی ماه مارچ شناسایی شده و تا ماه اکتبر زمانی که ما آنالیز کردیم مقام بیشترین واقعات ما در ماه جون و جولای داشتیم. شکلی که من بیشتر گفتم بیشترین واقعات مثبت ما نزد مردها بوده و یعنی نزد خانم‌ها کمترین واقعات مثبت در ولایت بور داشتیم. شکلی که ما شما بیشتر هم گفتم می‌بینید بیشترین واقعات و بیشترین کسایی که مثال بودن از مرکز ولایت بودن و دلیلی همین بوده که عرضه خدمات نسبت به ولسوالیات از مرکز ولایت بیشتر انجام شده و بیشترین واقعات نزد مردم دیتکت شده یا جمع‌آوری شده و دلیلی همین بوده که خانم‌ها کمتر به عرضه خدمات کووید-19 دسترسی داشتن.
Study or the data study was analyzed by me and also Professor Kabul. That study title is Epidemiology and Clinical Characteristics of 1,728 hospitalized patients with COVID-19 in Afghanistan. We have used the DHIS2 database and we are using the data of February 24 and between 17th August. And that we are going to about the background. In 1st December, the first case of pneumonia was found in Wuhan, China, and it's separated globally, including Afghanistan. And our study was to determine the impact of corona infection and COVID-19, as well as the demographics and outcome of the first hospitalized patients with COVID-19. And the methodology of the study is a retrospective multi-center case series. We have included 1,028 patients admitted to the national COVID hospitals in 24 provinces of Afghanistan. And all the patients known as COVID-19 by PCR test. And variation and characteristic and outcome were examined. And we also used the DHIS2 database for this study. Result of this study show first it was about on 24th February the first suspected case of COVID-19 confirmed by lab in Iraq. It was by PCR test, and the first date was on 22 March in Balkh province, and up to 17th August totally 101,208 samples were tested by PCR, and 38,045 cases were positive up to that time, and 1,389 diet was reported officially up to 17 August. It was about 3%, 65. And about the patients which we are analyzed, about 1,728 cases were hospitalized in National COVID Hospital. 26.2 of them was female, and 73.8 of was male hospitalized. The average of the age was 42.6 years with a standard deviation of 20.8. And the severe cases was about 18.3 and 33.5 need for ICU care, and 22.9 people were died. And about the diet over 60 years was 4 times greater than the people which was died because of COVID. It was less than 30 years old. And male were more like to be admitted to hospital is the conclusion points. With COVID illness and female and reported family history of clinical outcomes that provide insight to better understanding COVID disease epidemiology. And we're going to receive the question at the end of the session.
Dr. Nejat Safi is currently faculty and consultant pediatricians at FMIC. Dr. Safi, you have 7 minutes.
So today I just want to share some parts of my research that I made in last 2 months. And the topic is a clinical feature, laboratory findings and outcome of young children presenting with the multi-system inflammatory syndrome in children MIC in the midst of SARS-CoV-2 outbreak in Kabul. So we are still in this global pandemic and we are still learning about this COVID. So initially the thought were that the children are spared from this COVID-19. And the second thought was that the children are suffering from mild disease of COVID. But later on what happened, the pediatric population was described as a low factor for COVID-19. But few months later to this epidemic, a novel system of multi-system inflammatory syndrome in MIC is emerged. MIC, multi-inflammatory system in children or pediatric multi-inflammatory system syndrome was first identified in April 2020. It was by some doctors at Children's Hospital in UK and US. So in most study, there was a lag of several weeks between the peak of COVID-19 cases within community and the rise of MIC. Actually, there was an outbreak of a pandemic, and in the mid of this pandemic, this diseases increased the cases. Like previous COVID-19 disease or likely contact with someone who has had a COVID-19 is a limitation in this data because of the poor access to SARS-CoV-19 antibody testing. We suggest that this should not prevent the diagnosis and treatment of MIC after a careful exclusion of other conditions that is causing this condition in country with evidence of community spread as well. Thank you.
I would like to briefly present a snapshot of our study on screening of newly enrolled students at schools for early detection of prevalent health problems in Kabul province. You can see the number of observed cases, more than 80,000. Out of them, 29% had critical dental caries. And 2.4% of them had refraction error. Unfortunately, 0.4% of them had hearing loss. The majority of our observed cases categorized under the other problems. The majority of them were normal cases, just we had few cases from which were suffering from the other health problems like ear, dental, and ENT problems. So the plus point of this study was that out of those observed cases, 31.5% of them referred to the nearest health facilities based on the previously agreed upon reference sheet and established mechanism. So they received the required treatment in the public health services, and out of them, 68.4% of them received information, education, and counseling or behavioral change messages. So these were 2 plus points of this study. Conclusion. The prevalent health problems of school students can be prevented, early detected, and timely managed through universal implementation of health screening and expansion of basic school health services, and will contribute to the retention rate and quality of education. The health screening of newly enrolled students is a cost-effective intervention. It only costs around $1 per student, including the basic logistic supplies, the training of the data collector and assessors. It is well accepted and highly demanded by students and their family, including their caregivers. Most of the caregivers, including the parents, were unaware that their children are suffering from the hearing loss. Recommendation. The school health screening is a cost-effective intervention and should be integrated into the national health and education system in the country. This is the message for the policy and decision makers. Targeted communication for development interventions are needed to increase caregiver awareness and promote healthy behaviors. Further explorative or analytical studies are recommended to explore the why for the mentioned problems. You can see some pictures during our data collection and screening. Thank you so much.
University Hospital, Karachi, Pakistan, by Dr. Sattin Ahmed about impact of COVID-19 on lab professionals, result of a virtual survey at a high-volume clinical chemistry lab. I hope Dr. Sattin Ahmed is online.
Assalamualaikum and a very good afternoon, everyone. I'll be presenting today impact of the COVID-19 on lab professionals, results of a virtual survey at a high-volume clinical laboratory in Pakistan. Next slide, please. These are my co-authors. Next slide, please. As we all know that the COVID-19 pandemic emerged on the global scenario earlier this year, and it has taken the whole world by an emergent storm. The COVID-19 has activated an unanticipated and unparalleled worldwide crisis, which has drastically impacted many organizations in terms of social, mental, and financial well-being, alongside the revenue generation. And these also include the clinical laboratories globally as well. Next slide, please. In a developing country like Pakistan, more than can you please go back to the previous slide? More than 90% of the labs in Pakistan are small and without adequate physical and manpower infrastructure. Furthermore, working consultants designed the questionnaire. To validate the questionnaire, we initially filled as a pilot by one resident, a faculty member, and one senior technologist. And the responses were recorded on a Likert scale of 1 to 5, beginning from strongly dislikely to strongly agreed. The study was granted exemption from the Institutional Ethical Review Committee, and informed consent was acquired electronically before the beginning of the survey from each participant, and the anonymity was maintained. The stats was performed using the Microsoft and Excel and SPSS. Frequency and percentages were calculated for gender, experience, and designation, while the descriptive results based on the responses were also recorded. Next slide, please. After informed consent, a total of 78 responses were received. Female gender was predominant. Majority of the participants were senior technologists, but all cadres of the lab staff were included in the survey. Education level was master's for majority of the staff, and the experience ranged from 5 to 10 years to more than 20 COVID-19. The staff agreed that strong policies were adopted. However, on the other hand, when there was adequate and timely provision of PPE, most of the staff agreed, with a few proportion in the disagreed category as well. Majority of the staff also agreed that they are satisfied with the cleaning practices adopted amidst the crisis. And majority of the staff again agreed that the periodic safety training provided to cope with the pandemic and such emergency crisis was adequate. Whereas, the impacted lockdown has led to difficult transportation situation in the city. Staff were not able to be in the job on time because the transportation services were not readily available amidst the lockdown. So when they were inquired about that, the organization has taken satisfactory initiative for transport arrangements, majority of the staff were in the disagreed and the strongly disagreed category. Next slide, please. So various studies globally have explored the impact on the physical, mental, and social well-being of the health professional, but studies focused on clinical laboratory professionals were missing, and this was the first one to project the view of the laboratorians. And the well-structured survey is an ideal way to do it. And amidst the pandemic, due to the SOPs of social distancing, we validated, provided a valuable database to establish correlations and association between policies and practices using a virtual Google Docs document. The response rate of 78% potentially impact the efficiency and productivity. However, it is too early to predict when this pandemic will terminate and the unforeseen consequences that might continue. The findings of this virtual survey paves the way and provide us certain lessons to prepare for such unpredicted crises in times to come. Next slide, please. Thank you. Tribute to my laboratory staff working amidst the pandemic as they're serving on the front lines. Thank you.
Today's presentation topic is the frequency of hypothermia in preterm units less than or equal to 34 weeks of gestation during transportation from the liver of pregnancy.
Sorry, can you talk near to mic, please?
Can you hear me? Am I audible?
Yeah, it's not good.
Am I audible?
Yes, please go ahead.
Sure. Next, please. This is the outline of my presentation. Next. Neonatal hypothermia is an irregular thermal condition in which a neonate's whole body temperature falls below 36.5 degrees centigrade, leading to a different adverse clinical situation and increasing morbidity and mortality in neonates. Next. Hypothermia in neonates occurs due to the mechanism of heat loss. The heat loss mechanism includes conduction, convection, radiation, and evaporation. Next. According to a study, 51% neonates were observed to be hypothermic on admission to the NICU. Among those, 80% were born at 23 weeks of gestation and had a birth weight less than 1500 grams. Moreover, mortality was increased in 72% of hypothermic neonates. However, 10% neonates were diagnosed with hypothermia in a study that contributed towards increased hospital stay and increased morbidity and mortality rates. According to a Pakistani study, hypothermia was observed in 64% of people. This study was intended to answer the following primary and secondary questions. Next, the current study used cross-sectional study design. The study was conducted in NICU at a private tertiary care hospital, Karachi, Pakistan, among all the preterm units less than or equal to 34 weeks of gestation. The data collection was conducted in a 3-month time period and purposive sampling technique was used. Next, data was collected on the basis of eligibility criteria. Inclusion criteria of the study was preterm units less than 34 weeks of gestation, born at a tertiary care hospital, Karachi, preterm units having direct admission from the labor room to the NICU. Neonates were admitted from the nursery, pediatric ward, emergency room, or outside the hospital. The NICU were excluded from the study. Next, the sample size was estimated on the OpenEpi software version 7.2. A minimum sample size of 1 or 2 was required with an anticipated frequency of hypothermia among preterm units of 49.5% with 5% at level of significance and the precision of 10%. The final sample of 107 preterm units was able to collect. Next, a checklist was developed by the primary investigator to help with the help of the literature. The checklist was adapted and modified from a tool previously used in the previous study done by Ali et al. The components adapted from the tool were gender, birth, weight, gestational age, the temperature, admission, and Apgar score. However, in addition to these components, this checklist included antenatal data, postnatal data, body temperature at 4 different time intervals, vital signs, complications, NICU stay, and morbidity and mortality. Next, a pilot was done on 10% of the sample size and minor changes were made in the checklist. Next, the data analysis was performed using the SPSS version 20.0. The quantitative variables after testing for normality assumption were calculated either by means, standard deviation, or a median, respectively, and were assessed by independent t-test and Mann-Whitney test. For other categorical variables, The frequencies and percentages were reported and they were calculated using chi-square of Fisher-Exact test. While looking for chi-square, if the frequency in any of the cell were less than 5, the Fisher-Exact test was used. Repeated measures ANOVA Bonferroni test was used to assess the difference in the body temperature of the neonates at 4 different time intervals. A p-value of less than 0.05 was considered significant throughout the analysis. Next. Following measures were taken to maintain the ethical integrity within the study. Next, while assessing the demographic characteristics of the study participants, 58 neonates were between 32 to 34 weeks of gestation. Next, a mean weight of all the sample was 1399.5 grams with standard deviation 360.83. Next, Apgar scores were assessed at 3 different time intervals. Apgar scores increased with increase in time. At 1 minute of birth, 65 neonates had Apgar score between 8 to 10. Next, the body temperature of preterm neonates were measured at 4 different time intervals that were 1 minute of birth, 5 minutes of birth at the time of transfer to the NICU and on arrival at the transfer. At 1 minute of birth, 13 neonates had moderate and 2 had severe hypothermia. At 5 minutes, 13 neonates had moderate and at the time of transfer to the NICU, 34 and 49 neonates had moderate hypothermia on arrival at the NICU. The study findings showed that the rates of moderate hypothermia increased on arrival at the NICU. And similar findings were found in the literature. Next, the study identified that the difference between the body temperature of the preterm neonates at 1 minute and 5 minutes of birth at the time of transfer to the NICU and on arrival. At the NICU, the body temperatures gradually decreased from 1 minute of birth to the arrival at the NICU. The significant difference was observed between the temperature at 1 minute of birth and on arrival at the NICU. The difference in the body temperatures may be due to the decrease in the incubator warmer temperature because of conduction, convection, and radiation. A few other studies also measured the difference in the body temperature at the different time intervals and found similar results. Next, please. Thank you. Furthermore, it was observed that the neonates having hypothermia on arrival at the NICU would tend to develop in different clinical conditions that could increase the morbidity among preterm neonates. Similar significant findings were observed in the literature. Next, please. The study concludes that there is a high frequency of hypothermia in preterm neonates less than or equal to 34 weeks of gestation during the transportation from labor room to the NICU. Next, please. Following are the references.
Mr. Haniyat, you can start your presentation.
All right, great. Well, good afternoon, everyone. I'm Benya Chick, and I'll be presenting the Corona Check application, which was implemented recently by the Al Khan University in various countries. I'm filling in for my colleague, Samara Lukonbala. Next, please. Okay, so first of all, so the Corona Check application aims to address the screening of patients or populations for the COVID-19 virus. As of now, as of December 16th, about 72 million cases have been confirmed worldwide, with about 1.6 million deaths as reported by the World Health Organization. Healthcare systems are prepared for the worst, and there are second waves of the virus coming in, and it's giving an adverse impact on health systems and the global economy. Only a few healthcare systems worldwide have been equipped to deal with the massive number of infections, acutely ill patients, as well as the population level anxiety that comes with the COVID-19 virus and the lockdowns put into place to contain the virus. So it's basically in efforts to limit the spread of infections and to reduce the footfall at the Al Khan University hospitals. and preventive measures to limit the spread, the Digital Health Resource Center at Aachen University has developed and launched the Corona Check application. Next, please. Next, please. Okay. Here's the visual of the Corona Check application itself. It is available on the Google App Store, and I'll be talking a little bit more about it. Next slide, please. Okay, so in terms of results, so these are a little older, but from April to October, there have been about 30,000 plus downloads. And until then, about 67,000 users had completed the self-assessment tool. And here you can see a breakdown of the plans that were in terms of results. And so you can see about 47% of the users were just asked to stay at home, which means that these 47% may have visited the hospital based on the symptoms that they were experiencing. And this avoided, all the rush and the footfall at the hospitals. Similarly, Plan B asked people to, 28% of the people that took the test to seek non-urgent care through teleconsultation. So they also were not visiting the hospital. So next slide, please. Here it is. So the results are, the application helped prevent unnecessary hospital visits for 75% of the cases, curbing the risk of the spread. It has enabled more than, I think it's around 6,000 individuals to tackle myths and misconceptions through the educational videos. These videos are regarding the virus, the symptoms, precautionary measures like how to wear the masks and physical distancing, and these videos are based off the videos that the World Health Organization has released. And so basically the app has helped reduce harm, risk, and spread of COVID-19 by directing 25% of high-risk patients to seek immediate medical attention and follow strict social distancing measures. So these are the results of the application implementation in each of these countries. That is it from my end. Thank you all.
Thank you, Ms. Mohammed. We are at the end of our session. We can take a few questions. If you have questions, you can ask. We request all presenters to come in front and be prepared to answer questions. Please, presenters.
have 10 presentations in this session. Let me introduce the Honorable Session Chair and Co-Chair, Dr. Ataullah Saidzai and Dr. Muhammad Omar Mashal. Session Chair, Dr. Ataullah Saidzai. Dr. Saidzai has done his MD from Kabul Medical University in 2003 and received his Master's degree of Science in Epidemiology and Biostatistics in 2008. Dr. Saidzai has worked as Director General of MNE-HIS since 2005. Since he has started working, major improvement has been achieved in bringing all health data under one umbrella, which was clustered under leadership of different departments previously. Dr. Saidzai has also provided technical support in important health research such as DHS. Furthermore, he has worked in key positions focused on MNE-HIS and research with different national and international NGOs such as LMG MSH Afghanistan, Aga Khan Health Services Afghanistan, John Hopkins Bloomberg School of Public Health, Aga Khan University, Brak, Afghanistan, and has worked as consultant with PMG Local Fund Agent for Global Fund. Furthermore, Dr. Saidzai has worked as biostatistics lecturer at Kabul Medical University for Public Health faculty students. Additionally, he has published many articles in national and international journals. Now, I'd like to introduce the session co-chair, Dr. Muhammad Omar Mashal. Dr. Mashal is graduated from Kabul Medical University and obtained his PhD degree in Public Health and Epidemiology from Tokyo Medical and Dental University, Japan. He has worked with national and international organizations in different capacities. He has published many articles in national and international journals and is now currently working as academic manager of FMIC PGME program. Chairs, you are now requested to please begin the session.
First presentation is on risk factor associated with female breast cancer in patient diagnosed in tertiary care hospitals.
Of Almighty Allah and permission of honorable colleagues, I am going to present my study. It is a cross-sectional study of emergency hysterectomy during 1 year at Malalai Maternity Hospital, which is a tertiary care hospital. Actually, the hysterectomy or emergency hysterectomy is a procedure that we use it for removal of uterus after C-section or normal vaginal delivery, or also during postpartum period. This is a life-saving period when life-threatening events happen during postpartum hemorrhage at all women who are delivering, normally or by operation. So the globally maternal death data of this life-threatening event is around 27.1 deaths in the recent study of 2014 globally. The objective of this study is to find the incidence of emergency hysterectomy, its demographic characteristics, and its causes during 1 year at tertiary care hospital of Malalai. According to the methodology, it's a descriptive cross-sectional study designed during 1 year from March 2019 to March 2020 and 18 to 2019, and the convenient sampling used to access the record, and it's retrospective record review of Malalai Hospital, and it's analyzed by program Excel 2016. If we see the results from the all women admitted to Malalai Hospital during 1 year, the total women were 30,040 patients, and from all of them, 6,611 had cesarean section, and out of them we had 21 patients of cesarean hysterectomy or emergency hysterectomy. So if we see the causes of emergency hysterectomy, you can see that at the top we can find placental adhesion, then uterine atonia, abruptio placenta, placenta previa, and uterine leiomyoma. They are all the causes of cesarean hysterectomy. If we see according to maternal age that which one is the mean age for all these women during their reproductive age, so we can see that the major cases are from 31 to from 31 to 34 years old. So the mean age is 33.5 age for mothers, and if we see by gestational age, the mean age is 38.5 weeks. And most of the cases are from 36 up to 40 weeks of gestation. Furthermore, if we can see according to risk factors, the major factors are previous cesarean section and addition of placenta are two risk factors that we find during our study. Most of the cases received blood transfusion, and 3 of cases we had more than 6 pint blood transfusion. That we can say that in one case we had 16 pint blood transfusion at one lady, and we saved her life. Another hand of our study is the fetal outcome, or besides mother, we also assess fetal condition as well. If you can see here that from all 21 patients that we did cesarean hysterectomy, 17 cases we had a live fetus and stillbirth were 7, and the total number is 24 because we also had multiple gestations. If we see the complication, overall complications, we had wound infection, bladder injury, fever, paralytic ileus, relaparotomy due to hemoperitoneum, and in all 21 cesarean hysterectomy, we didn't have any maternal death. In discussion, you can see that we find out that increasing number of cesarean section serve to complication like increasing abnormal placentation at point of scar at every lady, and also it increased the atonic uterus at postpartum, and they all have a direction to go to the cesarean hysterectomy. And if we compare the incidence of the cesarean hysterectomy, even though it is from the one hospital, Malalai Hospital, but it is the biggest hospital which accepts all admitted cases which are referral from private hospital or from governmental hospital, and also home delivery. We accepted all cases from all over the Kabul and also other provinces. So therefore, our incidences near to other neighbor countries like China, Pakistan, India, Nigeria, but it's lower in Colombia, United States. Actually, if we see the result, we can say that the risk factors and all other factors which we can compare to our neighbor countries, and further studies need regarding this study, because it is a retrospective study, and we need, of course, some prospective study in this case to have more information and go further in the future. Thank you very much.
Dr. Zikrullah Basit. Dr. Zikrullah Basit is graduated from London Medical University. He has joined FMIC in 2016 and finished his postgraduate qualification in 2020 in French Medical Institute for Mother and Children. Now he is a consultant pathologist in Human Pathology Center. Dr. Basit, please, you have 7 minutes to present your research.
Cancer is also called the disease of the genome. It affects mainly the genome machinery. Cancer is the leading cause of death worldwide. According to the WHO, it is estimated by 7.6 million people died due to cancer in 2005. They insist if the action is not taken, it will be involve 84 million people in coming 10 years. Among all, breast cancer is a worldwide problem which affects mainly the breast parenchyma. With 1.7 million incidents. Surprisingly, more than 90% of symptomatic breast lesions are benign. Breast carcinoma primitively classified as a histologic pattern. They involve ductal cells and lobular cells. The two main histologic patterns of breast cancers are ductal carcinoma, invasive and invasive lobular carcinoma. They affect about 75% and 15% respectively, invasive ductal carcinoma and lobular carcinoma. Whereas 10% of less common breast carcinomas are mucinous, metaplastic, papillary, and inflammatory medullary carcinomas. There are few histologic picture of breast cancers. This is a ductal carcinoma, which we see under microscope. This is a lobular carcinoma and mucinous carcinoma, which we see under microscope like this structure. Several studies have been conducted in Afghanistan and outside country to identify the risk factor, frequency, and also clinical pathologic feature of breast cancer. However, we don't have any published data about risk factor associated with female breast cancer in Afghanistan context. Our objective were to identify the risk factor associated with female breast cancer in Afghanistan. A case control study design was employed. The study was conducted in French Medical Institute for Mothers and Children, Jamhuriyat Tertiary Care Hospital, and Istiqlal Tertiary Care Hospital. Our cases were 202, 201 cases and 201 controls. With a p-value of significant. Our finding provide that the age at first minority, age at first baby birth, level of education, smoking, and family history of breast cancer are strongly associated with breast cancer in Afghan population. However, to educate female about these risk factors will decrease the burden of breast cancer in Afghanistan. These are my references. Special thank you for Dr. Jamshid Jalal, Thank you.
Ladies and gentlemen, I would like to present on behalf of my team, Dr. Najib Imam, Mr. Farid Hamad, and Dr. Said Rahullah Ahmad Zaid, the outcome of congenital heart surgery at FMIC. This is the outline of my presentation. Before going ahead, it's important to know that a congenital heart defect is a problem with the structure of the heart, and it is present at birth. And we also know that the congenital heart defects are associated with, the literature shows that maternal exposure to smoke, diet, especially deficiency of folate, and obesity of the mothers. And for this reason, routine fetal anomaly scans at greater than 18 weeks is vital to detect the problem and manage accordingly. It affects 1 in 150 newborns and almost 81 in 10,000 people having CHD. And the mortality varies from 2.5 to 11% globally. The significance of this study is that it is the most common non-infectious cause of the death globally, and CHDs are associated with lifelong comorbidities requiring frequent healthcare services. For this reason, CHDs have to be detected as early in life as possible to be managed accordingly. The purpose of this study was to explore the clinical outcome of patients who have undergone surgery for congenital heart defects. Our methodology is, you know, that FMIC is a member of the IQIC, which is a global international organ in the hospital. The higher the category, the more is the risk for mortality and other complications. So majority of our patients are lying. However, there are some patients who are lying in category 3 and 6, and our mortality was higher, 16% in these risk categories. The ICU stay and ventilation. This is almost comparable, even much better than the other sites. If you can see, the ICU stay of our patient was 36 hours. The demographic characteristics presented by our patients resemble what is reported by the literature. Patient clinical outcome after surgery is considered within the international benchmark, and complications were minimum and well managed. FMIC as a tertiary care hospital can be a safe referral site for patients requiring cardiac surgery. I must acknowledge these people. I'm not taking time on this. Thank you.
Dr. Sheikh Ahmad has done his MBBS degree from Punjab University, Lahore, Pakistan in 2002. In 2007, he has done his MCPS in internal medicine from College of Physician and Surgeon, CPSP, Pakistan. In 2011, he passed exam of FCSP Cardiology from Punjab Institute of Cardiology, Lahore.
My topic is left main percutaneous coronary intervention in a patient with unstable angina. First of all, we have done such like some 5 patients of angioplasty, left main coronary artery disease. Left main, usually, first I will explain the left main because coronary arteries start from the coronary sinus. From the right coronary sinus, there is a right coronary artery. From the left coronary sinus, left main coronary arises, which further divides into left anterior descending artery and left circumflexor. So this PCI angioplasty of left coronary left main stem is seldomly, rarely performed in other centers. So we have done this angioplasty for 5 patients during last 3 months. Around 5% of patients undergoing coronary angiography have significant left main coronary artery disease. Both American College of Cardiology and European Society of Cardiology recommend revascularization for all patients with 50% or more than 50% stenosis of left main coronary disease, regardless of the symptomatic status. The anatomic site of left coronary stenosis is important really to do the bypass. And the other thing is what the circumflex artery was small. If we lost this circumflex, it was not so important because it was small. And the third thing is what urgency. So we are afraid that if you shift to the OT for this surgery, we may lose the patient. So on the basis of these 3 things, we performed this angioplasty of the left coronary artery, and patient reduced the pain. We did the PCI of left pain and achieved it successfully and without complication. So after 1 month and 3 months patient, we have done follow-up the patient and have come without any complaint, and he is taking regular treatment. And all other patients, we have done the 4 other patients also are very well with the angioplasty. So this was that case. Thanks.
We have Shri Muhammad Alizada, who is going to present prevalence of horizontal strabismus in pediatrics patients at University Eye Hospitals. Janab Ustad.
اسکوینت یا استرابیسموس یا حول که یا چشم پیچ میگن، یکی از امراض است که زیادتر اگر در نزد اطفال مراقبت نمیشه سبب میشه که چشم چی شود؟ تنبل شود. پس اینا بسیار زود ضرورت به تداوی دارند، یا جراحی تداویش یا عینک است یا عملیات. خب ابجکتیو ما چی است؟ گفتیم که فیصدی شیوع واقعات استرابیسموس در شفاخانه کلی چی شد؟ از تاریخ 25 مارچ تا 25 سپتامبر 2019 در شفاخوانی کدیچی. متد متریالش متد ریسرچ دیزاینش به شکل کراس سکشنال است و موقعیت شفاخوانی کدیچیش است. تمام واقعاتی که در اینجا داشتیم 1862 مریض بود که 67 مریض مربوط میشه به واقعات اسکرین که انکلوژن کریتریاش تمام اطفالی که از سن 1 تا 16 سال بود شامل و کسایی که پایین‌تر از سن 1 سال بود و از 17 سال بالاتر از اون و کسایی که اسکرین عملیات شده بود از خارج شده بود. تمام ارقام توسط جمع شده بود توسط SPSS و اکسل پروسس شده. نتایج ما نظر به جدول میگیم که از نظر سن زیادترین فیصد واقعاتش نزد بچه هاست که تقریبا 55.2% میشه. از نظر سکس بچه ها گفتیم فیصدی زیادی واقعات شده تقریبا 55.2% است. دهلی 44.77% و ایران رشت کلینیکش 47.44% است. شکل ایزوتروپی شفاخانه UH 73.1%، هنگ‌کنگ 27%، نایجیریا 60%. دو دقیقه. خب استدی لیمیتیشنش چون یک تحقیق در یک شفاخانه بسیار کوچک شده که محدود است، پیشنهاد میکنیم که در شفاخانه چشم اکثریتش اجرا شود تا در تحقیق درست‌تر و جامعی بوده. و کانکلوژن ما که گفتیم به این دیده شد که زیادترین واقعات نزد بچه هاست و ایزوتروپی شکلش بیشتر است نظر به الترنیت شکلش بسیار بیشتر است نظر به یک طرفه و بچه ها نظر به دخترها زیادتر و ثابتن. تشکر.
Dr. Salahuddin has graduated in 2009 from Bath Medical University as an MD and he joined FMIC Orthopedic Department as Junior Doctor in 2010. In 2013, he successfully passed the entrance exam of the PGME program for the orthopedic department and graduated successfully in 2017. He is currently working as orthopedic surgeon at FMIC since then. Dr. Sir, you have 7 minutes to present your research work.
It is cleft a significant cause of morbidity among children in Afghanistan. This is my outline. Cleft is known as a congenital thalapsopanovirus deformity. It's one of the most common congenital foot deformities globally. We have two types of cleft foot. One is a typical cleft foot and another is atypical cleft foot. The etiology or the exact cause of cleft foot is unknown, but these theories are various theories are proposed. The incidence rate is 1 to 2 per 1,000 live birth. Males are affected more than females, and also bilateral cases are more than unilateral cases. We can evaluate these patients by these Cranny scoring system. We have another scoring system also that's called Demiglo, but most commonly we use the Cranny scoring system that we can evaluate the pre-op and post-op of patients. We use the radiology evaluation just to determine the surgical planning. We have two types of treatment for these patients. One is the conservative treatment and the other is surgical treatment. The conservative treatment is most commonly we use the Ponce method that worldwide used. That the result of this treatment is more than 90%. And also we have operative treatment that we can use the soft tissue release tendon transfer or bony procedure. Our cases are bilateral. Boys are affected twice as often as girls, but girls prone to complication twice as often as boys. When age of treatment is increased, the result of our treatment is decreased. Because when the age is increased, we do the surgery, we have a lot of complication. and a higher percentage of our patients required surgery because of delay in seeking the treatment, and our success rate is 81%. Recommendation: training on conservative and surgical treatment of clubfoot conducted through arranging conference, workshops, or CMEs to improve the knowledge, and MOP should develop guidelines and training programs for gynecologists, midwives, and pediatricians about the referral of clubfoot patients to pediatric orthopedists for proper and early management of these cases. Thanks a lot.
Bismillahirrahmanirrahim. Today I am going to present a web-based database for validating dried blood reference interval of amino acid or units enrolled in AMANI study. In conclusion, the web-based database CLEAR developed by the Mayo Clinic, Rochester, USA assisted us to establish our own reference interval for dry blood spot amino acid and compared it to the other labs worldwide. Thank you so much.
Thank you so much. To come to the stage, and if we have any question.
Furthermore, he is a field epidemiologist graduated from 2-year field epidemiology and laboratory training program FELTP and NIH Pakistan in 2011. He has worked in MOPH in various capacities as HMIS officer, director for public health training, director for disease early warning system use, and director for grant and service contract management unit GCMU and MOPH for more than a decade, in which he was managing service delivery contracts with NGOs almost all over the country. His key achievements are designing and conducting 7 rounds of intensive 6 weeks public health trainings, from which more than 1,200 healthcare workers graduated. In addition, he has written a useful and important book in local language on introduction to health management. He has more than 40 publications in national and international journals. During work tenure, he has contributed in development of many guidelines, strategies, and policies in MOPH. He has been a member of many committees appreciated by MOPH for excellent accomplishment. Currently, he is leading and managing field epidemiology training program, intermediate in Afghanistan, as a technical advisor, which is supported by CDC and GHD MFNet at Afghanistan National Public Health Institute. Dear Chair, you are requested to please begin the session.
Thank you very much. Directly we'll go to the session from Karachi by Dr. Hena Shahabuddin, who will present the Association of Gender with Outcome of PCI Percutaneous Coronary Intervention. Are you with us, Dr. Hena?
Today I'm going to present my research on the association of gender with outcomes of percutaneous coronary intervention. Next, please. Next slide. Okay. A prospective study was conducted from October 2015 till June 2017 in the coronary care unit of Al Khan University Hospital. Total 184 patients who underwent PCI were included and equally divided into 2 groups. Males as group A and females as group B. 30 days outcome measured in terms of modality following PCI was noted. Chi-square test was applied to compare the mortality in both groups. Relative risk was calculated. Post-stratification chi-square Fisher-Excek test was applied. P-value less than 0.05 is considered as significant. Next, please. Thank you very much.
We'll go to the second presenter, who is Ms. Faiza Khanam. She is not available, that's why the turn will be given to Mr. Abdul Wahid Amar Khail, who will present the retrospective analysis of trauma patients at the tertiary hospital and emergency department. Mr. Wahid Amar Khail, the floor is yours, please.
Patron and outcome trauma patients admitted to emergency department at the tertiary care hospital in Kabul, Afghanistan. A retrospective review. Principal Investigator Abdul Wahid Khail, Supervisor Vice Muhammad Karani, and Coordinator Taibullah Bantawal. And this is our presentation outline. Background. Trauma is any physical damage to the body caused by extrinsic forces and is one of the leading causes of mortality and morbidity around the world. Injuries are a global public health issue and kills millions of people around the world each year. On arrival to the emergency department, trauma patients need immediate and systematic life-saving intervention. Literature review. 5 million annual global deaths are attributable to injuries, with 90% occurring in low-resource settings by 2015. According to Poverty Commission report, mortality due to trauma in Afghanistan is 21.1% of overall mortality in the country. In 2015, WHO's report has shown that in Afghanistan, trauma cases increased by 24% in compared to 2017 in same time. The objective of the study is to describe trauma patterns and outcome and treatment outcomes in patients admitted to emergency department of 10th Medical Institute for Mother and Children in Kabul, Afghanistan. Also, we identified that in inpatient admission status that 81 of 116 patients were admitted in ward and 35 were admitted in ICU. But however, in other countries, in our studies, we saw that majority of the patients were admitted directly to the OT. And the reason is that majority of our patients were sent from other hospitals, and we had very less number penetrating injuries. That's the reason that why majority of our patients are admitted to the ward. GCS or Glasgow Coma Scale at the time of admission. Majority of the patients admitted to through emergency department of FMIC were in moderate coma. It means that their GCS was 9 to 12, and followed by deep coma, and we had 39% patients were admitted in deep coma. They were like, and also we find that the average length of stay of each patient at FMIC were 8.9 days, and a patient stayed from 1 to 60 days at FMIC. And the arrival to the hospital and nature of the injury. Given that FMIC is a reference site for the most critical patients, the mortality is reported higher. Recommendations. Here we would like to recommend strengthening coordination between pre-hospital and emergency care providers for timely management of trauma patients, an ATA certification for all the cadres practicing in emergency departments, establishment of the standardized trauma care protocols with full compliance. We will acknowledge all emergency nurses of FMIC, nurses and physicians, and medical record of FMIC, Department of FMIC, and from AQH Umardas to Dadat, Research Bureau of Emergency Department. And these were our references. These were also our references. Thank you.
Dr. Soufiani has been graduated from Kabul Medical University 10 years ago, and he has vast experience in health management, health service delivery, research, training, teaching. In early years, been members and secretary of many boards like IRB, like Science Epidemiology and Research, and also Health and Pharmaceutical Journal. And he has been working as a head of clinical research and public health studies. And for those viewers, Dr. Soufiani, you have some.
The study was about stillbirth and experience of parents and healthcare workers. The title is I should have seen her face and witnessed experiences and practice of the care related to stillbirth in Afghanistan. It was a qualitative study. It was conducted in Kabul, rural and urban area. Background: stillbirth rate is 27 per 100 birth in Afghanistan, and it's so higher than other country. It's 9 times more higher than other countries. Let us learn about stillbirth. Parents' experience or perception of care related to stillbirth, or health providers' practice and perception of the care it provides. Parents' well-being can be affected by healthcare providers' infraction, and our finding and result is based on this genetic format. Communication and information. It was just all of them is a quotation of the healthcare providers, medical doctors, father, mother, and like this. For example, the first one is about the mothers. Delay or avoid communication is stillbirth dialogue. To protect mother or avoid blunt confrontation. The mother said, when my baby was born, the doctor prepared its place, and I was waiting that why didn't they put my child there? I waited for a long time, and then I saw the baby was under the table. I waited for half an hour. They did not tell me because they were afraid of dura or placenta. They want to cure about this one. And what about another mic? Is it available? Because I'm going to read some parts.
We don't talk about it in front of the we only
because there's lots of text and all of this question. Yeah, I'm going to use this from here. Conclusion and implication. Parents' desire of following stillbirth in Afghanistan is similar to other settings, like studies. Healthcare providers' perception and practice on what they think is best for parents contrast the parents want. Sustainable evolution in helping providers practice some sympathetic, respectful, other incentive. Many opportunities to improve the experience of care of women and their family around stillbirth in Afghanistan. Short-term measures to consider about the prenatal bereavement, about the psychosocial, about the guidelines we should provide, we should advocacy for this, because there's nothing about, for example, psychologically they don't have any mention to the parents, to the mothers, because they have children and they have lots of problems, but they didn't receive any, for example, advice, any another from the health facility. Provide opportunity for improvement communication between parents and healthcare providers. Encourage sensitive respect for care, treatment of women and baby. And about decision making, about the opportunity for memory making, opportunity for career momentum. And this is the team of the research, 3 persons from State University, Professor Aluti, Professor Kano, Professor Ashraful Alam, and 2 persons from Ministry of Public Health, Dr. Rashidi, Dr. Rasuli, and one of our colleagues from WHO, Dr. Adlan Bashir, and also 3 data collectors, Nasrin Qureshi, Fariban Nasri, Rohilal, and all other persons we acknowledge. And this is the reference we have mentioned about.
Thank you very much. Thank you. And invite Abdul Qahir Jawad, who is an organizer committee now. He will be a presenter. He has done his bachelor in nursing from Kabul Medical University, and currently he is coordinator for nursing education services.
My PowerPoint is about enhancing staff knowledge, enhance staff knowledge on nursing care plans to improve patient outcome and FMIC. An introduction, I should say that nursing care plan or NCP is a problem-solving model that makes it a useful tool which promotes critical thinking. Another, implementing 5 interrelated steps of nursing care process: assessment, diagnosis, planning, implementation, and evaluation is a systematic and dynamic way to deliver nursing care. NCP is essential for all nursing practices, applicable in all care settings. Nurses in Afghanistan are not adequately trained on NCPs during their academic stay. In conclusion, or in the recommendation, the demographic characteristics of the participants indicate that they are young generation and investment could be made on them to enhance their knowledge. Although the perception of the participants was good on use of NCP, their technical knowledge on NCP was low, requiring training. A training program is developed to be implemented to improve the staff knowledge and skills on NCPs. This is my references. It's not over. Thank you.
For giving me a chance to present my quality improvement finding. The title of my presentation is Ensure Safe Surgery to a Standardized and Constant Approach to Safe Life. This is our team member. I am self the team leader, Shabana Hillian, head nurse of surgical unit, and my supervisor is Muhammad Wais Qarani, nursing administrator. My presentation focus on the following. Before going ahead, let us define what is safe surgery. Safe surgery is vital for patient safety, and it is significant patient injury and adverse event, sentinel event, and incident which can result from wrong surgery, wrong procedure, wrong site marking, or the ongoing concern for the hospital. Rationale for the selection of this quality project was inadequate and ineffective communications, lack of patient involvement in the site marking, and procedure was performed, timeout was done without full participation of the team, and policy was changed with the inadequate and inconsistent of staff education and implementation. In the conclusion recommendation, that to avoid wrong patient, wrong surgery, and wrong site, a strategy needs to be in place to ensure patient safety. Staff knowledge is vital to ensure compliance with this strategy. It is recommended to cover 100% of the staff and meet the hospital target on these measures. In this presentation, the outcome of 163 participants is present, which will be followed with the remaining staff during 2021. This is my presentation reference. Thank you.
Ms. Muradi she has done his Bachelor of Science in Nursing from Isfahan Medical University 2007. She has more than 10 years of experience in nursing. She started as a care of nurse here in FMIC in 2009 and then promoted very soon as a clinical nurse instructor in 2017. Currently, she is managing the adult medical surgical ward as a head nurse since last 2 years. She also has led many small-scale quality projects and also research, and she has been in many committees here in FMIC. For yours, please.
Home healthcare professional. This project is led by myself, supervised by Vice Muhammad Qarani, Administrator, Division of Nursing Services, and team members were Dr. Bashir Ahmad Nazari, Dr. Ahmad Rashad Akbari, Mr. Rashmatullah Azimi, and Mr. Muhammad Moin Omardot. Before presenting the result, I would like to briefly discuss the topic. Patient safety is one of the main components of healthcare services. If we want quality, effective communication, it's a prerequisite. And also, it's a key element for successful collaboration within the healthcare system. The Joint Commission established international patient safety goal. That goal number 2 was improve effective communication, which include verbal telephone recorder, panic or critical test result, and handover. Deficient communication among healthcare providers can result in frustration and distrust among healthcare providers and may lead to inferior level of care and higher risk of error. One of the strategy which was already in place, the monthly audit by Quality Assurance Department. The second strategy is handover checklist along with spot check and daily round by HN and HF department are the main strategy for sustainability. In this project, we doing the pre-test and post-test. However, we covered a limited number of staff. However, it's part of our plan to cover the remaining of the staff, 92 doctors, 169 nurses, and 26 allied health professionals from now until first quarter 2021. These are our references, and thank you.
And I think the knowledge is another one. So how do you think that how can we learn from this and not repeat the same things in other areas? Site marking, communication is very, very important. So are we covering all the areas now in the site marking? What is our compliance here now? Is every surgery patient who is required to be assigned, or are we doing it?
This is dental vision. We can say yes. It's like in the inpatient is like they also between of 90% and 100%.
So everybody is doing now handover process properly.
Yes.
And who is monitoring those?
HN and HF department monitoring this.
Thank you.
About research methodology which conducted by APHI, especially about midwifery, we have in every of our training we have included midwife. About all the field of health, we have the chance for every person who is working in health, for example, about midwife, nurse, and everything. We have announced about research methodology course in our APHI Facebook page, and also if the person want to check the research methodology training, we are going to have a form. The person should fill the form, then we are going to have in every research methodology 5% out of 15 we have a transfer the people when they have filled the form. And maybe there's about 10, 12 or up to 50 sometimes the peoples which have applied for research fill the form and share with us back, share back with us. And then you're providing a panel, and the panel choose sometimes 3 up to 5% from the person which filled the form. And also the nurse can fill the forms, but still, unfortunately, we didn't receive any person come from nursing department and fill the form and said that I want to receive this training. But about the nursing, received about maybe about 1 hour ago, I received a message about FTP, and they requested we should include the nursing in FTP. Yes. And
this is my requisition.
Miss Marufa Muradi.
I wish I could have attended the entire day, but I couldn't. I attended the last 2 presenters, and I was thrilled. Why I was thrilled that the hospitals are not here to, basically our role is to provide a safe care. It was not a surgeon that we don't have, we have the surgeon, we have the nurses, we have anesthetists, everything. But just because of one of the process and overlooked, we make a mistake. Thank you very much for showing this presentation, and I think this is a learning for all of us. Also the second presentation, communication. Everything is communication in medicine. If we communicate well, you can convey everything. If you convey everything appropriately to the patient and their families, they will never come back to you and ask why this had happened or why that has not happened. I think communication is everything between our staff, between our patients, families, and the most important thing is when we are leaving a patient and going home, if we consider that patient can be my figure, is research. We should learn how to do this and how to do this. We are using all the time the evidence-based, we are talking about evidence-based practice, but we are always using those evidences from the Western world, but we are not using from our own area. We should know what is the best way to treat a tuberculosis patients. We should know what is the best way to look after a mother during the pregnancy. We should know how to look after the child. A person who is taking care of a child in this weather from your Badakhshan area, the coldest areas, I don't think anybody has seen those kind of harsh scenarios anywhere else. So we should be producing those research. So I would like to extend my sincere thanks to His Excellency, the French Ambassador, the Acadian representatives, and also to Dr. Abdullah Fahim delivering a speech on behalf of the Ministry of Public Health. It is very important that we must understand that this arranging conference is a difficult and a long time-consuming exercise. Entire team of this scientific conference and quality convention team, Tawab, your team, and our scientific committee, thank you very much for putting together, giving us additional time to prepare this conference. Although this year we have not been able to invite so many people just because of the COVID and social distancing that we are putting. This conference, we were thinking of cancelling, but I said no, this is a tradition, we should never cancel. Even if we were not allowed to hold, even bring one person here, we could have done online. My request would be, we should communicate to people who confirmed earlier to participate. They should have participated because it's an academic, it is a learning process for all of us. My colleagues here who have studied abroad, they know how important it is to attend the research seminars because these are mandatory, especially when you are doing masters, when you are doing PhDs, they have to, because this is their part of the curriculum, studying on that. I would also like to extend my sincere thanks to Canadian government for supporting financially. Every year since the beginning they have been helping us to launch this conference and quality convention, and to the AFD for helping us and providing the opportunity to do this. It was again not possible without the help of our normal partners, and thanks to our partners for helping us and giving us this chance. I would like to extend my sincere thanks to our security, local police, NDS. Because of the security situation, they have been around the hospital looking after you. You might not be knowing there are so many people around the campus to facilitate security, and this is one of the most important things here. I would like to extend my sincere thanks to people who have been serving you for food, tea, and other things, Saeed and his team. So thank you very much. Our cameramans, recorders, everybody who has done their contribution. Our consultants, I know it is difficult to leave the patients today. It was a working day. Despite that, they are here today. And I hope that we will be able to do more next year. Inshallah, next year is going to be an exciting year in 2021, since we will be celebrating 15th years of the FMIC, and there will be many more opportunities to come. About the conferences, about the learning, what we have learned over the last 15 years, and hopefully the corona situation is going to be a little bit improved, so we will be able to offer you more opportunities of learning and sharing your knowledge on the same time. I think this effort which has been put together by our IT team, thank you very much for helping and arranging this and put it all the way. This conference was live on our internet through the Facebook, through webinar, and hopefully many more people have seen it. And the last, I would like to extend my sincere thanks to all the people, including the maintenance, the housekeeping, you name it. If I missed something, I'm really sorry. And in fact, our jury, thank you very much for this. So Dr. Bashir and your team, where's your team? Thank you very much. The academic committee, marketing. Sorry, I missed. Communication. I would say this is not a marketing, communication team. Thank you very much for putting it together. Hopefully, we will not repeat the same thing again next year. But the situation was in a way, so we had to cancel and then postpone and then come back again. Because of that, some people have not been able to attend. Hopefully, next year, inshallah. Thank you very much, everyone, for being here and sharing your knowledge and listening to the presenters. God bless you. Have a nice evening. Thank you and good.